Welcome back, everyone. Today we are diving into the bread and butter of the orthopedic emergency room. If you spend 5 minutes in a level 1 trauma center, you are going to see a distal radius fracture. But the real question is it a Colles or is it a Smith's? Dr. Sarah, are you ready to get into the weeds of these wrist deformities?
Absolutely, Dr. Khan. These are classic, high-yield topics for any medical board exam. While they might look similar to the untrained eye, the direction of the displacement makes all the difference for the diagnosis and, more importantly, the treatment plan.
Exactly. I like to think of it like this. The wrist is the gateway to the hand. If that gateway is crooked, nothing works right. Let's start with the big one, the Colles fracture. Picture a 65-year-old woman walking her dog on a frosty morning. She slips on a patch of ice and boom, her hand goes out to break the fall. We call that a foosh, right? Fall on outstretched hand.
Right, the foosh. For the boards, remember that in a Colles fracture, the wrist is an extension during the impact. This force drives the distal fragment of the radius posteriorly and superiorly. Dr. Khan, you always have a great analogy for the look at this injury.
Oh, it's the dinner fork deformity. If you look at the wrist from the side, it has that exact same silverware curve. The distal part of the radius is pushed toward the back of the hand. Why does this matter clinically? Because if you don't reduce that fracture perfectly, meaning if you don't put those fork pieces back in a straight line, the patient loses the ability to flex their wrist properly. They won't be able to turn a doorknob or pour a cup of tea.
And from an academic perspective, examiners love to ask about the demographics. Colles is incredibly common in patients over 50, particularly those with decreased bone mineral density. If you see a distal radius fracture in an older patient, your osteoporosis alarm should be going off. You're not just treating a bone, you're managing a systemic condition.
Great point. Now, let's flip the script. What about the Smith's fracture? I call this the skater's nightmare. Instead of falling on an open palm, the person falls on the back of their flexed hand. It's essentially a reverse Colles.
Precise as always. In a Smith's fracture, the displacement is ventral, or anterior. The distal fragment moves towards the palm side. Clinically, this is often called the garden spade deformity because the wrist profile looks like a small shovel.
A garden spade, I love it. But here is the catch, and this is where I ask, why does this matter clinically? Because the Smith's fracture is often much more unstable than the Colles. Since the fragment is displaced anteriorly, it's hanging out right where all the action is. Dr. Sarah, what's the big neurovascular threat here?
It's the median nerve. Because the distal radius fragment is displaced anteriorly, it can compress the contents of the carpal tunnel. On an exam, if a patient presents with a Smith's fracture and starts complaining of pins and needles in their thumb and index finger, you need to be thinking about acute carpal tunnel syndrome.
Spot on. In the ER, I'm always checking sensation in that median nerve distribution. If you miss that, you're in trouble. And when I'm talking to patients about their recovery, I want to be the doctor of choice who explains that the how of the fall determines the what of the surgery. A Smith's fracture frequently requires a plate and screws, what we call internal fixation, because the muscles in the forearm are constantly trying to pull that fragment even further out of place.
That muscle pull is a key concept. The brachioradialis and the flexors are quite strong. If we don't counteract those forces, the deformity will return even after we try to pull it back into place. That's a high-yield reason why Smith's fractures often end up in the operating room, compared to some Colles fractures that can be managed with a simple cast.
It's all about stability. Think of the radius as the main pillar of the forearm. If the pillar is snapped and leaning toward the palm, the roof, which is the hand, is going to collapse into the carpal tunnel. We have to prop it back up.
Let's summarize the radiographic differences for the students listening. For a Colles, you are looking for dorsal tilt. For a Smith's, you are looking for volar tilt. Volar is just the fancy academic word for the palmar side. If the radius is tilted toward the palm on the x-ray, it's a Smith's.
And don't forget the ulnar styloid. Often when the radius breaks, it tugs on the ligaments and snaps the tip of the ulna too. It's a package deal. If you see one, look for the other. Why does this matter clinically? Because ulnar side pain can persist long after the radius has healed if we ignore the soft tissue damage there.
Excellent point. To wrap this up, if you're sitting for your boards, remember, Colles is a dinner fork from a foosh with dorsal displacement. Smith's is a garden spade from a fall on a flexed wrist with ventral displacement and a higher risk for median nerve injury.
Boom! That's the distal radius in a nutshell. Keep your eyes on the deformity, check those nerves, and remember that the goal is always restoring that pincer grip and doorknob turning power. Thanks for joining us today.